Okay, good evening, everyone. This is Dr. Grace Ondia. I will be your moderator for today. I am a physician based in Eldoret, and I'd like to welcome you all to this evening's webinar, which will be diabetes and aging. I think this is a topic which many of us may have interacted with patients who are elderly or aged, and I think it's a good time for us to have this presentation for us to manage our patients better. And Dr. Beatrice Omari, who is a physician and diabetologist based in Nakuru, will be taking us through unique considerations and goals of care. This is our first part of a two-part series where we'll be looking at diabetes and aging. So for this first part, we'll look at the considerations, the unique considerations, and the goals of care. And the second part will be looking at the issues of polypharmacy and complications that have to be considered in this age group as we manage them. So allow me to invite Dr. Beatrice to go on with the presentation. And in case we have questions, we can write them in the chat box or in the Q&A box, and they'll be answered at the end of the presentation. Welcome, Dr. Beatrice.
Thank you for the kind introduction, Grace. Welcome, everybody. Good evening, and welcome to today's CME. Today's CME will be discussing about diabetes and aging, unique considerations in this population, and the goals of care. We thought it was a good series to do because, as you realize now, in most hospitals, whether public or private, and most outpatient settings, the patients whom we are managing with diabetes are growing older. And as they grow older, it is not only diabetes, but they have other geriatric syndromes, which we must be aware of. And these geriatric syndromes also interact with the diabetes, and we cannot ignore them even as we set for them goals, because managing the diabetes well is, of course, for them to live longer and have a better quality of life. But sometimes aging also reduces the quality of life. And so sometimes you find that even as we manage our diabetes, we find there are certain points at which our management may sort of interact in a negative way towards the certain goals of care that we want to achieve. So it's important that we try and look at this patient holistically and see what is manageable, what is achievable, and what will actually make the patient's quality of life better. So I'll go on to the first slide where we put in a case presentation. And the reason why we put in a case presentation is because I felt it was going to be easier for us to appreciate what we were discussing having this case on board. So the case presentation is a patient whom I actually saw in the clinic. She's around 65, a female patient who has had type 2 diabetes for about 10 years. She was actually brought to the clinic by her son, and her son was concerned because he had noticed that his mother had started developing memory loss over a period of slightly more than 6 months. And he noticed also that in her chart, where she records her blood pressure and sugars, that she had been having some elevated blood pressures ranging systolic above 150, diastolics above 90, but the mother declined that she does not have an elevated blood pressure, and she doesn't have systemic hypertension. When we sent her for lab work to evaluate, how well she's faring, her HbA1c actually came to 10%, 10.1%. But the patient's book was noting that, her fasting blood glucose was good. Her records were showing in the morning, and typically what she did was a fasting blood glucose. And her fasting blood glucose was ranging between 6 and 8. Her medication for diabetes, she had been using mixed-add insulin, 20 units in the morning and 10 units in the evening. And she is the one who was doing her self-injection. So this lady was living with her husband, but her husband rarely accompanied her to any hospital visits, whether she was going for diabetes care or also for this other clinic which she mentioned. So she mentioned actually when her son popped out of the room during her examination that she's also HIV positive and she's using ART. Of course, she was not able to name the ART that she was using, so that now had to come up in a subsequent visit. That's when she actually came with the medication. So I think the presentation just tries to outline who are these patients whom we define as old age. And we'll talk about how does type 2 diabetes manifest in the aging population, what are geriatric syndromes, and how do we individualize glycemic control in these particular age groups. So what is the definition for old age? So we have two definitions. The United Nations defines an older person as someone who is 60 years and older, okay? But according to WHO, and this was a definition that was released in 2024, their age for old age was from 65 and above. So they had three categories, and the categorization also sort of depicted the type of care this person was likely going to receive. So a person who was between 65 and 75 was categorized as young old age. And a young old age person is this person who is transiting from a working life into retirement. Then there was an age group of between 75 to 85, which they call advanced old age, where functional losses begin, and we see a lot of them. But in patients who have diabetes, quite a number of them will already begin to have functional losses in between the age group of 65 to 75. So some of them, you'll see it much earlier rather than much later. Then patients who are 85 and older are classified as very advanced old age. And these are patients who need to accept that special care and support is needed. So one of the challenges I think I see with elderly patients is that they do not accept that, as they're growing old, they need more assistance. Then it is imperative that their support system, whether it is their children, grandchildren, whoever is available, they need to be aware that even if this person reasons in a rational way, they require special care and support. And I think before we also leave this slide, it's important that we appreciate what is the definition of aging metabolically. And that is slightly different from what I've just given there as age. So here we're talking about a physiological decline in function and the functional properties of an individual, either at a cellular, tissue, or organ level. So we begin to see an impaired ability of the person's physiology to adapt to stressors. So age actually causes a decline in our homeostatic reserve. So the capacity of our organs to be able to withstand stress reduces, and that now makes the patient more susceptible, especially when they face certain infections or certain homeostatic abnormalities, whether it is dehydration or fluid overload, and of course now that increases their risk for both morbidity and mortality. So you'll find also when we are describing things like frailty, which are some of the geriatric syndromes, those are some of the things we're looking at. How is this person's ability to withstand these stressors that come with illness? So a bit of epidemiology about aging. So yeah, so you can see here a bit of projections from some of the data. Some of this was gotten from WHO. You can see 80% by 2050, 80% of older people will be living in low and middle income countries, which is actually where we are. What I think I found interesting was that by 2020, the number of people who are aged 60 years and older outnumbered children who are below the age of 5. So it means there is an epidemiologic shift to our patients. We are living longer. So more than, the rate in which people are being born, patients are living longer. And that means that we will reach a period in which a significant number of our population will be old, and they will need much more assistance than what is currently available. So you can see there by 2050, people aged 50 years and above will be around 500 million. And I can tell that majority of the people who are listening into this presentation by 2050 will be in some category of those age groups there, whether it is young, old, advanced age, or very advanced age. So it is a reality that as much as we are advancing in terms of medical care, our patients are living longer. The fact that they're living longer is that we're going to see them much, into their old age, and we need to be able to see how to take care of them in a more comprehensive way. So, sorry, I have a bit of challenge with the slides. So the other important consideration with our patients, especially the ones who are living with diabetes, is that they're not the same. You will meet patients who are elderly, they have diabetes, but you'll find some of them might be elderly onset disease patients. So we're talking about patients who are diagnosed with diabetes at the age of 65 and above. And we do see quite a number of those. So they're sort of recent diagnosis. Then we have the ones who have had long-standing diabetes, patients who are diagnosed for, in their middle age or in their early years, and they're living up to their old age. And you'll realize that as you're taking care of them, you'll have a whole range from very relatively healthy, strong individuals who are robust. Then you'll have another group who is quite frail and they have multiple comorbidities. And then we'll also see patients who have this concept we're talking about, which is geriatric syndromes. So geriatric syndromes actually just refers to a certain group of clinical conditions, which we see much more in elderly patients, which tend to occur because of that deterioration in function in particular organ systems. And most of them are multifactorial. So if in terms of etiology, you will not talk about them occurring because of only one specific cause, but you find that the fact that this patient has diabetes does impact on some of these conditions. Of course, one of the commonest we see is cognitive impairment and dementia. One of the things that literature and evidence does show, and in multiple studies, is that patients who have diabetes will tend to have a higher prevalence of dementia. Both hyperglycemia and hypoglycemia does contribute to cognitive impairment and dementia, and also hyperglycemia does contribute to a higher incidence of Alzheimer's disease. So majority of these patients, as they grow older, they will have either mild, moderate, severe cognitive impairment, and even dementia. So in dementia, we tend to see patients losing their recent memory, but retaining their past or their long-term memory. Delirium in the context of diabetes will tend to occur more, especially when they have a stressor, whether it is a stressor because of an infection, whether it is a stressor because of an organ dysfunction. So you will see, or a stressor in terms of what else? Metabolic changes. So you will see this same patient who is elderly becoming delirious either because they have pneumonia, they have gotten a stroke, they have now uremia with encephalopathy. They're developing encephalopathy because of hyponatremia. So those kinds of things will tend to make them have acute lapses in terms of their level of consciousness. Now they're drifting in and out of consciousness. They are appearing confused. They're not able to become alert to communicate. Unlike a patient who has dementia, who will be able to be alert, may or may not be able to communicate, but you realize that a lot of the conversation you're having, this is a person who is unlikely to give you a reasonable response. Commonly, we also see frailty. Frailty basically tries to describe patients who are very vulnerable to stressors, especially falls and injuries, and mostly also has been used to describe patients who have multiple comorbidities, and also who, because of the challenges they're having in terms of their medical conditions, they also tend to, have malnutrition. So you'll see malnutrition also as a dominant feature in some of these patients, poor feeding. And in some of them, you even find that these are patients who had diabetes, but over time, because of poor feeding, they're developing malnutrition. It is like their diabetes is actually almost going into remission. And it's not really going into remission, sort of regressing to the point whereby we are even able to completely withdraw all their diabetes medications, and they're able to maintain normoglycemia. So in such a situation, it's not necessarily a good thing that, you're saying, oh, your sugars are perfect. It should tell you that metabolically and in terms of nutrient intake, there definitely is a problem. They're not able to maintain their energy balance. You will see a lot of sleep problems, probably because of partly incontinence, which also comes with poor glycemic control, especially for the male patients. Incontinence occurs sometimes because of hyperglycemia, sometimes also because of urinary infection. We're seeing it much more enhanced in patients also who have lower urinary tract symptoms because of BPH, but also women are also getting incontinence because obviously the pelvic floor muscles are not able to help them control their bladder, and then the neurogenic effects that we see with diabetes as well. Then, of course, the hearing problems. Constipation sometimes comes because of poor intake, partly also because of the neurogenic effects of the digestive system because of having diabetes for long, because of some of the medications our patients are using. Some of them are quite high doses of biguanidine metformin, which also contributes sometimes to constipation and sometimes to diarrhea. So you will realize that most of our patients whom we're managing who are in the advanced and very advanced stage will have one or more or some of this, and will impact how to manage their diabetes. So there's certain metabolic changes that happen with age in patients that may sometimes be outside diabetes, but in diabetes, what we tend to see is the change in body composition. So as patients age, they're losing muscle, they're gaining more central obesity, and central obesity obviously now contributes to insulin resistance. So that is one of the features that we do see. There's quite a bit of physical inactivity, probably again because of the muscle wasting. And then for other patients, it's also because of fear of falls. For other patients, it's lack of balance. While for others, it's because of the osteoarthritis. So they're in a lot of pain and they limit their movement. Then now you realize that these same patients, apart from insulin resistance, they're also having, beta cell apoptosis and beta cell dysfunction. So mainly the type of diabetes we see is significant postprandial hyperglycemia. Like in my patients, you realize fasting sugars are not so bad, but her postprandial sugars would go above 15. So for this kind of patient, sometimes when you're trying to do fasting sugars for diagnosis or for monitoring, you may actually not be able to fully appreciate the glycemic aspects unless probably you're doing pre and postprandial or do a HbA1c or probably do a glucose tolerance. But you can see the challenges of maybe trying to give them glucose, then check the sugars after. But doing a pre and maybe a 2-hour postprandial may give you a good idea about the glycemic variability. So the other unique consideration about these particular patients is the fact that they do get quite a bit of macrovascular complications. In fact, in our wards, they are the patients who are admitted most because of strokes or myocardial infarcts. And they are the highest patients with diabetes and stage renal disease. I'm sure in most dialysis centers, most of the patients who are in dialysis are in the age of 65 and above. However, these are the same patients who unfortunately are excluded from clinical trials. So you realize that what is considered as standard of care and the evidence, for example, from some of these cardiovascular outcome trials, most of the time tend to exclude these particular patients or the patients with multiple comorbidities because they generally tend to have risk of drug interactions is high or adverse events with medication. You find that evidence from the clinical trials cannot be just blanketly applied to this particular age group. And even evidence, for example, from the things like lipid lowering, statin therapy, high dose statin therapy, lower targets in terms of blood pressure control, antiplatelet therapies. And these you can see are the measures that we are using either for primary or for secondary prevention. Most of these patients have been excluded. For example, for lipid lowering, most of the evidence is for patients below the age of 75, but yet most of our patients who we see and who are getting stroke, quite a number of them are above the age of 75. So you find that even when you want to apply the evidence does not guide you specifically for that 85-year-old, or that 90-year-old that you're managing who's probably had a microvascular complication. So bearing that in mind, then when we evaluate these patients, it's important that we look at, that there are specific geriatric syndromes that your patient will have, and they will increase in them specifically the risk for hypoglycemia. And you can see one of the top most highlighted one there is cognitive impairment or dementia. So this is the kind of patient who may not remember that they injected themselves, and then they will go back and re-inject. Or they will not remember that they took their medication, and they will go back and take their medication again. So that is a common thing that I sometimes see in patients who have dementia, because they do not remember whether or not they took their medication. The risk of overdosing themselves is quite high. And then the other aspect about frail patients, patients who are quite weak, patients who are not very mobile, patients who are quite wasted, those are not the type of patients who you want to be very aggressive in terms of your glycemic control. Patients who are malnourished. And then the last part is a patient who is having multiple medications. So polypharmacy is basically described as patients who are taking more than 5 drugs at a time. And generally speaking, most of these patients will be taking more than 5 drugs at a time. So that puts them at risk of drug interactions. And sometimes those drug interactions will either increase the plasma concentration of a drug that thus obviously contributes, for example, to hypoglycemia if the patient was taking some anti-diabetic medication. So any patients who have those specific geriatric syndromes, their risk for hypoglycemia is significantly high. Then, of course, the comorbidities that increase the hypoglycemic risk, we know topmost is chronic kidney disease, which unfortunately, most of our elderly patients already have some element of kidney insufficiency in one form or the other. As you've realized, if they're male, the risk of benign prostatic hypertrophy leading to obstructive uropathy and renal failure is quite high. And if they are, and already if they have long-standing diabetes, the journey of long-standing diabetes does predispose them, into kidney disease. And then a significant number of them also have heart failure, which also predisposes them to chronic kidney disease. So if they already have chronic kidney disease, they have heart failure, they have liver cirrhosis, either because of non-alcoholic fatty liver, but mostly some of them also because of alcoholic liver disease. They have significant muscle wastage, or they have sarcopenic obesity. So sarcopenic obesity is where a patient predominantly has central obesity, but if you look at their limbs are significantly wasted. So they are also at a high hypoglycemic risk. There is enough evidence to show that these particular patients very high risk for hypoglycemia. However, the other aspect that I was trying to bring out in the case presentation is this issue of glucose variability. So we see a lot of elderly patients who will have sugars going as high as 20 at some point, and then going as low as 3 at some point. And you're trying to figure out what is causing the swing in terms of why does it go very high sometimes, and why does the sugar go very low sometimes? So that sometimes can be because of their eating habits, what medications are they taking? And then you can see also patients some of these patients have had quite a long duration of diabetes. So you're talking about significant, very low beta cell reserve. And a lot of them basically might not be, unfortunately, very well managed with some of our orals, which we use, the sulfonylureas, the metformins, and we do sometimes put them on insulin, knowing very well that the insulin again puts them at risk of hypoglycemia. So sometimes, depending again on the type of insulin they're using, if they're using a biphasic insulin like Mixtard, expect, and if they're not very consistent in how they're using it, sometimes you will expect that they will get hyper, they don't inject, then they eat, then they get hyper. I even had a patient, I think last week, who injected himself with Mixtard twice within a period of 2 hours, injected 26 units in the morning. And then 2 hours later, when he checked his sugar and it was 19, 3 hours later, he repeated another mixed tide of 20 units. So you can see that obviously was going to lead to a significant hypoglycemia later in the course of the day. So there are going to be some complexities in terms of glucose dynamics. And then the other issue is the social support. Some of these patients are widowed. Some of these patients live alone. They are basically living with a carer whom they feel, may not manage them as well, and they still want to be in charge of their own treatment regimens. Some of them have low literacy. They may not be able to read some of the medications that we bring. One of the rules I had to initiate in the office was that any patient who comes, they have to come with their medication, even if, it's a prescription that was written before, because when they bring them, sometimes you find that they're double dosing on a similar brand. It's just that, it's a similar medication. It's just that it's a different brand. They're using metformin from one company and metformin from the other company, and they think that it's different medications. So we take into account the fact that some of them have low literacy. The healthcare system is not able to support them appropriately. The social networks may be present, but may not be present as much as we would like, and see how best can we help them in all that complexity so that we can give them a more appropriate management plan. So trying to get to good. So how do we assess these geriatric patients? The assessment may not just be you alone as the healthcare provider. You may need plus the nutritionist, because you realize that their nutritional needs may not be fully met by you as the healthcare provider. They will not have a low carbohydrate diet like what we prescribe typically to our young and middle-aged adults, sometimes of type 2 diabetes, and have obesity, and we're trying to manage weight and other things. Their nutritional intake might require slightly higher carbohydrate. Their protein intake will actually be something like 1 gram per kg body weight per day, and it's not 1 kg of mass that we're talking about protein. So that might also be calculated by the nutritionist. The nutritionist will also help you to achieve good vitamin intake. So there's a whole package in terms of what is this person supposed to be eating, and the nutritionist will significantly help you to manage that. If you're able to access physical therapists and support in terms of physical care, because quite a number of them, as we've mentioned, have comorbidities. They have osteoarthritis. They are frail. They are not moving without support. There's fear of falls. There's muscle loss. So that assessment can help the patient in terms of what activities can they be able to do, because the exercise is also important in terms of the lifestyle modification. This exercise is supposed to help them maintain muscle. It's also supposed to reduce the frailty, and the exercise also significantly helps to reduce the cognitive impairment and the dementia. So the exercise regimen that actually, we should be prescribing to them would be exercise for at least an hour, 4 to 5 times in a week. And we're not talking about, some of them, as I mentioned, might not be able to walk, but even some level of resistance training so that they can be able to achieve greater muscle strength. That significantly helps, again, to ensure flex, and part of the exercise also will include flexibility, because stiffness is another common problem that they tend to have across joints. So the social support is also quite important, because that is the person who will be motivating. In some cases, that is the person who's going to be giving the medication. In some cases, that is the person who will be coming to the hospital and finding out what is the care plan, what are we going to achieve, because these patients have many comorbidities, and we will sometimes have to prioritize what is going to be treated and what will wait. So what is urgent? If your sugar is high, that is urgent and it's giving osmotic symptoms, okay? Can we manage the osteoarthritis for now with mild to moderate pain medication, as we see how this will be managed better, maybe in the future. But if we don't manage, for example, the hyperglycemia, then even the pain threshold will still remain to be significantly low, and the patient will have lots of pain. So it's important that as you write your management plan and you listen to everything, because they have a lot of complaints, prioritize what is important. And one of the most important things becomes symptom relief. What symptoms are they having? Because there's what you as the healthcare provider want to achieve, and then there is what is the priority to the patient. What you want to achieve is, apart from symptom control, you want, good quality. You want to reduce complications. You want to do risk reduction. You don't want your patient to get stroke. You don't want your patient to get heart attacks. But at the moment, they're having pain. They are having, uncontrollable urination because of hyperglycemia and, the osmotic diuresis that comes with it. That's what needs to be managed. They're having pain. That's what needs to be managed. You may probably need to incorporate the part for risk reduction a bit later as you reduce these other symptoms that the patient is manifesting. So it's important to determine the treatment priorities, which geriatric syndromes are they having, how best can we address them. So on the first part there is a part of the frailty and the cognitive impairment, and there is a big role for exercise, as I've mentioned. Diet, please work with a nutritionist. The nutritionist will help you a lot in terms of coming up with a meal plan. Our elderly patients are very selective when it comes to what they want to eat. And then they may not eat very big meals. So sometimes you may be content with 2 meals, but in those 2 meals, they're eating food that is nutrient dense. And then encourage social participation. So the other important aspect that we need to be recognizing every time when we meet them in both outpatient and inpatient is the issue of hypoglycemia and polypharmacy. So hypoglycemia will always require adjustment in the medication. If the patient is having hypoglycemia, please relook and adjust. And that again also comes because we have many medications that we are using for diabetes, and especially the hypoglycemic risk is higher in the patient who is using sulfonylureas and is using insulin. So which sulfonylureas are you using? Obviously, if you're using glibenclamide, the risk for hypoglycemia is highest. However, if you need to use a sulfonylurea, then evidence, at least the studies that have shown you have less hypoglycemic risk with gliclazide, you may use that, but you need also to have close monitoring to see whether the patient is still experiencing hypoglycemia. You can see there, sulfonylurea dose requires reduction if there is hypoglycemia. There is that aspect of de-escalation that if the patient, for example, is on insulin, is insulin regimen appropriate? If these doses are high, is there a way we can reduce them? And probably add on oral medications that are relatively safe without increasing their risk of hypoglycemia. So deprescribing is part of treatment. As the patient becomes more frail, and as we've talked about muscle loss and reduced eating, then the patient sometimes, yes, requires less medication. So that is also an important consideration to do. The other important thing that you also need to consider is treatment simplification. So remember, in a patient who, because if this patient is going to be taken care of by a sibling or a son or daughter or a carer, they are not likely going to manage complex treatment regimens. So can these medications be combined? And so combination therapies really help. Can you get medications, for example, if it's for blood pressure, can it be 1 tablet? Can it combine everything that you need? If that's possible, yes. And the carer understands this is the blood pressure tablet. If it is for diabetes, is it possible that they can take a combination therapy so that we have less tablets and less frequency? Even medications that have frequent dosing tend to be missed and or used inappropriately. So can we get simplified regimens that can be administered by somebody if they're on insulin and biphasic insulin is giving them hypoglycemia, or the frequent dose, even twice a day is an issue. Can they take it once a day? Can they be put on a basal insulin as long as you're not having very extreme levels, and especially the hyperglycemia? Because a lot of our elderly patients are suffering from overtreatment. So we are being overly ambitious in terms of our HbA1c targets with good medicines, yes, but they don't gain extra benefit by you trying to achieve that HbA1c of 5.5%, and then you're putting them at risk of hypoglycemia. They may be more comfortable with less hypoglycemic risk, less mortality, with a HbA1c of 6.5, okay, and less treatment. And you'll have less falls and less also mortality. So those are some of the things that we need to appreciate. So overtreatment, so we are being very ambitious in elderly people, that does not give them extra benefit. And then under treatment, so the patients who are pretty robust, they don't have lots of comorbidities. They're managing their diabetes. You see a HbA1c of 8, and somebody does not want to do adjustment of that treatment, and yet that you can get it better. So our elderly patients face both situations, whereby in one group they're overtreated, probably because they can afford it, and we want to give them the best glycemic control that we can, forgetting that the lower the sugars are, the higher the risk of hypoglycemia, which also comes again with some of the risks that come with aging, with like the falls, the hypoglycemia causing increased mortality, versus again on the other side that this patient who has minimum is relatively healthy, less comorbidities, can afford to have a better sugar than probably the one that they're having right now. So the other important aspect is social participation, social support. Please don't allow elderly patients to come for hospital visits alone as much as possible. Try to encourage them to come with somebody younger. Sometimes I have an 80-year-old and an 85-year-old, and that's the partner who has brought, the husband has brought the wife, and you're looking at them, and even as you're trying to arrange their priorities and what you're going to treat, and the treatment plan appears quite complex, you wonder if they're going to remember everything. So try to encourage that. Let somebody younger who participates in the care be involved in the treatment plan, be involved in the hospital visit, be involved in the follow-ups. If there are labs that are supposed to be followed up, then let them be involved. So one of the last slides that we're going to be talking about is the individualizing of HbA1c targets. I borrowed this one from one of the, I think it was the Japanese Society for Diabetes, but it incorporates what the Americans, the Europeans, and in a simpler way tries to help us sort of individualize your HbA1c without, again, being very lenient, but also without having very tight glycemic control. So the first part, the categorization talks about is the patient background and the health status. This patient who has cognitive function that's intact, no impairment of activities of daily living, is not using drugs that are associated with, severe hypoglycemia, like our insulin, our sulfonylureas. Some of them you can actually achieve safely a HbA1c of less than 7 without a lot of risk. But you can see there, they've also categorized for you that in this patient who's between 65 and 75, you want your HbA1c on the lower side to be around 6.5. And this one who is above 75, you want it to be, on the lower limit of 8, especially if they're on the drugs that are associated with severe hypoglycemia, because you do not want to up-titrate a dose and then have hypoglycemic episodes. But the ones who are already beginning to have mild cognitive impairment or mild dementia, and there's mild impairment or basically very minimal impairment, you can see the range is a bit higher, especially if they are on sulfonylureas or hypoglycemic aid or insulin. where they're talking about a lower limit of around 7, but they can allow a HbA1c of up to 8. But the ones who have significant cognitive impairment, significant comorbidities, and they have to use insulin or sulfonylureas, working with around a HbA1c average of about 7.5, even up to around 8.5, because it may be difficult to try and intensify treatment without again increasing their hypoglycemic risk. So I hope then this now puts you in a picture whereby if they're using metformin and they're tolerating it, if they're using DPP-4s and they're tolerating it, if they're using SGLT2s and they're tolerating it, you can see those options tend to work much and may be much safer. The only caveat I may put to the SGLT2s is that especially for the patients who are having, recurrent urinary tract infections, you can see they're in the, severe cognitive impairment and maybe have a higher risk of dehydration. You might want to be careful because these are patients who you'll find that, the risk of infection is quite high. Especially I see it with patients who have, BPH, and, you put in the SGLT2 and within a few weeks, they're already having, dysuria, you treat it, then again in a few weeks because of urinary cases. So those are some of the patients who you find, putting them steady on such drugs may not improve their quality of life. Other considerations might be, the time to benefit of your medication. So SGLT2s and the newer drugs have undergone cardiovascular outcome trials. And in these trials, they were shown they actually reduce mortality, there's a mortality benefit. But if a patient has, expected lifespan of less than 3 years, really, the benefit there of the SGLT2 might not really be very evident. So again, the other consideration is cost. Are you likely giving this patient medication that's not only cost effective, that's also a simpler treatment regimen that's not giving them a lot of side effects, they're tolerating the medication, and there's actually benefit because sometimes the medication is added on and you can see the patient is, 95 years old and you're looking at quality of life, so those are some of the aspects. Some groups may say if you're expecting life expectancy is less than 3 years, there may not be much benefit of maybe adding the SGLT2 inhibitor on the treatment regimen. If you're adding it, for example, for cardiorenal or benefits. So back to our patient. So our patient had mild cognitive impairment. Her HbA1c with, she had poor glycemic control. So one of the things we discussed with her son was to set a target of around 7, and a BP target of around 140, which we were able to achieve with 1 tablet. He was able to provide, the patient with good social support. We agreed that he will be accompanying her to every visit. And we agreed that, he will be the one ensuring that the patient is able to take their medications as prescribed. He's the one who buys. Although he's not the one who administers the injections, the patient so far is still able to administer her injections. We had to reduce her mixed dose to 10 units in the morning and 10 units in the evening. And we added metformin with DPP-4 and an SGLT2, and she's tolerating it quite well. And, we were able to achieve a HbA1c of around 7.5 in the last visit, down from 10. The social support also significantly helped in terms of ensuring that the patient, remains on her ART regimen. We couldn't go higher on the metformin because metformin and dolutegravir can significantly increase the doses of metformin. So we had to maintain it at around 500 milligrams per day. So the combination therapies definitely did help to achieve good glycemic control. The reduction of insulin did help because now I think with the initial dose, she was eating quite a lot in the morning because she would get hypoglycemic episodes probably at around 10. We also used combination therapies for risk reduction because the mild cognitive impairment was most likely because of vascular dementia. So she's on a statin with clopidogrel, but as a combined tablet because we wanted a treatment regimen to be simplified. I think I will stop there and thank you for your time and probably open the session for questions.
Thank you, Dr. Beatrice, for an excellent presentation, just laying out the complexities and issues that surround managing elderly patients. And I think each of us has picked something from the presentation and hope we can do better in terms of considering a few other issues that we may not be thinking about previously, but now have been brought to the forefront for us to think about as we see these patients. So I see a few questions in the chat box as well as the Q&A box. I think I will read them out and then Dr. Beatrice can take them on. Is it good model for a diabetic hypertensive 78-year-old male who reports to record daily the blood sugars and blood pressures to take his drugs when measurements are high? That's part one. And is it a good practice with a goal to reduce polypharmacy and other complications of geriatrics?
Okay, so monitoring is good because we want just to have an idea about, are we able to achieve consistency in terms of whether it is blood pressure control or blood sugar control. But sometimes most of our patients, especially as they take their medication, what they tend to do is, because they're seeing good numbers, they're thinking that, that equals, withdrawal of some of those medications. So we do appreciate that, with blood pressure, from high, the lower, the better. But again, there are certain numbers below which there's no extra benefit. So it has a J sort of curve in terms of benefit. So if you're getting, numbers that are way below and the patient is symptomatic, that definitely warrants a reduction or a de-escalation of their treatment management. So the recording helps us to appreciate the trends, and the trends then determine, do we need less? But definitely there are certain situations where the medication is withdrawn, for example, when they become sick. So we see that, that homeostatic, the patient's blood pressures are not able to withstand, severe infections. So we see a significant drop in blood pressure during the times when they even come down with a common cold or, a diarrheal illness or malaria. And during that time, it definitely does not make sense for the patient to take medicine and the blood pressure is 90/50. But as now they recover in their normal physiology again, in states, you start seeing the numbers going high again. And then, the medication has to be reinstated back. But the issue of polypharmacy is common. And what we're trying to say is that it is important to classify our treatment regimens to, is this essential? Is this essential? Is this the priority? Does this interact with what the patient is already taking? Must this be treated right now? Or this can wait? What requires the priority? Can that be addressed? And then again, how do these medications interact? Because like I gave the example, my patient was already HIV positive. I don't have a different treatment regimen for that. She's using tenofovir, dolutegravir, lamivudine. That is her treatment regimen. I may want to give her more metformin because I want to reduce the amount of insulin. But I appreciate that if I do that, the dolutegravir is going to make the serum metformin levels go very high. So I have to keep it at the lowest dose that I can. And the 500, if that can still help me to reduce blood sugar and reduce interactions on this other side because I don't have a different ART regimen, it works. So it's about sometimes making, certain compromises, and we will not have a perfect balance. But at times, we have to appreciate that the treatment regimens are going to be quite complex, and the patient has to be treated. So what is going to be a priority, and we work with what is the priority. And as the patient gets better, there are certain things, we may say, maybe you don't need this pain medication anymore. You'll be taking a milder pain medication when you need to. Then, can we talk about this risk reduction now? Because of if we don't do something about risk reduction, then, you're still at the age group where there's a high risk of, of strokes. So yeah, that kind of thing.
Thank you for that extensive answer. I think we have some more questions on the Q&A box. Perhaps let me read out the ones that seem to be related to the topic of the day. Would you recommend combination of Lantus in the evening and gliclazide in the morning, as opposed to using a basal bolus regimen, which could be cumbersome to a geriatric patient?
Yeah, so for geriatrics generally, a basal bolus is a complex regimen. And you've seen, especially if this patient is frail with cognitive impairment, that is going to be a complicated regimen. The only challenge is when you're combining, okay, Lantus will be good for your fasting, but it will not be very good for your postprandials. And gliclazide still is a sulfonylurea. Be aware that there'll still be risk of hypoglycemia. Can the patient, for example, tolerate some metformin and a DPP4? That would be, a safer route, unless you're saying with the Lantus and this metformin with the DPP4, you're not getting, reasonably good fasting and postprandial blood glucose. Maybe that's the time I may consider the gliclazide. The advantage about gliclazide, again, is that, you can get small doses. You can get a 40 milligram, you can get a 30 milligram. So all of those are available. It's important then you will have that conversation with the patient about, how are they going to be checking for you their pre and postprandials. So that's probably what I would comment about that combination.
Good, thank you. Another question that is related to that one is, so for elderly patients visiting the diabetic clinic, at times we find one with weight loss. During repeated visits, you note that they're dropping weight and they're on Oglas, metformin inclusive. You evaluate and report they're feeding well. Is it right to switch to insulin, having in mind the effects of metformin?
Okay, it is. Metformin does significantly contribute in some patients to weight loss, especially the ones who are not having good glycemic control. And, insulin is generally an anabolic hormone. So you expect that, when they're going to be on insulin, that you're likely going to have them achieve good weight. The only thing is that you're going to be careful how much insulin and how you're going to go about it, because most of what is readily available is biphasic insulins. So they'll come in the form of Mixtard and it's and their analogs. And Mixtard is a combined insulin. So a patient who is going to be on Mixtard will have to have, a regular eating plan. So a patient who is staying at home alone, and there are people coming in the morning, and there are people living in the morning and then coming in the evening, that might not be a very good patient to put up. So there are many things that will help you to decide how you want the insulin to be administered. So if you're going to put them on for example, mix an insulin that's biphasic, be aware that the patient will need to eat more and need to eat a bit more frequently. Is that provision going to be provided by the social support? Because that is probably the most readily available insulin that we have. And then bearing in mind that there is also a risk of hypoglycemia if they're not getting meals appropriately.
Thank you. I think I hear you speaking a lot to social support in the context of our elderly patients, because these are the people who will continue to help with the monitoring.
Yes.
I still see another question concerning metformin. Someone asks, for aging who have been on metformin, at what point would you consider stopping it or at least adjusting the dose? How common is the risk for B12 deficiency and lactic acidosis in our population?
Okay, I don't think we have local studies for the numbers of the risk of lactic acidosis. It's mostly documented in the patients whose GFR is below 30. And it is true that in patients whose GFR is below 30, and they're still in high doses of metformin, there's increased risk of mortality in some of the studies I was looking at. So it's important that as we give these medications, we need to monitor the kidney function and see how it is. Quite a number of our patients have of our elderly patients have abnormal kidney function. And you'd be surprised that a just slight increase in creatinine to reach 200 in a person who is the age of 70, that is already a significantly reduced GFR. So those are, by GFR of less than 30, ideally that patient should not be on metformin. So, but vitamin B12, the deficiency, I do see quite a number of patients. I may not have data to tell you that there are 5 or 10, but I do see. And the reason is a significant number of these patients have been told having meat products is going to, is not good in patients who have diabetes. So that, and is going to increase their lipid levels. So quite a number of them have eliminated animal, products from their diet. They're having a completely plant-based diet. So I have seen patients who have developed significant vitamin B12 deficiency to the point where they're even developing pancytopenia, and we have needed, transfusion and subsequent numerous vitamin B12 injections. So the incidence is there, and especially because, as I've said, if the nutritional aspect is not well dealt with, that can develop, and it's important to take it into consideration. Remember, in the natural progression of type 2 diabetes, if your patient has had type 2 diabetes for more than 10 years, the challenge now becomes that their response to some of our oral medications, especially if they're going to be on sulfonylureas and things like that, their beta cell function will have significantly reduced to less than 25%. So majority of the ones whom we are seeing above 15 years, even if they're on metformin plus the sulfonylureas, we find their glycemic control is quite poor. And majority of them at that point, we start having discussions about, insulin is required. It's because the beta cell function is significantly reduced. Does that mean the metformin doesn't work? No, the metformin works, but the sulfonylurea most likely does not work. So the insulin comes in now because of beta cell decline, and that is the natural progression. So in our patients, for example, who are diagnosed at middle age or early years, yes, you expect by the time they're at 65, they'll have very little beta cell reserve, if depending on how well their sugar control has been managed over time. However, it's important also to appreciate that now that we have these medications like the DPP-4 inhibitors, remember part of their benefit is, some level of, beta cell preservation. So you're not exhausting that beta cell quite as rapidly as the person who is using metformin plus, for example, a sulfonylurea. The one who is using a sulfonylurea, beta cell exhaustion will happen quicker than the one who is not using a sulfonylurea.
Great. I think that is well answered. I think the last question I see regarding metformin is the best time to take it. Is it before meals, after meals, with meals? Perhaps you can mention that as we move on to possibly another set of questions.
Wow. Will I say it is before meals, after meals? I honestly, I have never thought about it, but I will have to look into literature and see whether there, does the physiology, does the pharmacology say it should be before or after? I would have to check on that. Or it may be, Dr. Wandia, do you know the pharmacology? Must it be before or after?
Well, this is anecdotal. I think I would need, I don't know if there's anyone in pharmacology who is in the attendees, they would help us with this. But most of the time, because of the nausea and the other GI effects, I see most patients prefer to take it after the meal. But perhaps we need clarification with that, especially because of GI side effects.
The GI effects definitely are, that sometimes with a bit nausea, a bit of dyspepsia and constipation and things like that. And as I think probably my comment about the metformin might be, to increase it slowly. Sometimes, newly diagnosed patient and has been given metformin 1,000 milligrams twice a day. The risk that the patient will not tolerate that dose is quite high. So you want to start slowly. You want to start at 500, maybe twice a day. Give that patient time, for their GI to, and then see whether, they're able to tolerate a higher dose. Because yes, you want to achieve glycemic control, but our patients read. So the moment they identify that the GI effects are likely because of this medication, the likelihood that they're going to want to accept it as part of their treatment regimen is going to be very low.
But I think that's well answered. I think it doesn't seem to have a lot of interaction with meals, so it's generally safe to take it after.
It's safe to take either before or after.
After is
After.
what
Okay, thank you for that. I appreciate.
Taken after. Good. I think I see also a few questions on incontinence and neurogenic bladder. Someone who asked, what do you do for neurogenic bladder or stool incontinence in this geriatric population after ruling out infections as the cause? And there was also one question concerning female incontinence in females. So I don't know if you're in a position to answer that. It may be a bit out of scope, but neurogenic bladder for sure is something we come across in the elderly population. So maybe you could make a comment on that.
So I think my comment would be, at least it's important to make sure that the patient is not having any infection. It's also important to, reduce diuretics, because some of them, are taking high doses of diuretics. If they can, if it is possible, because I know some of them will take them because they have heart failure and, and we may not be able to be rid of it. But if we're taking it, for example, just for blood pressure control, can we use something else that will reduce, the diuresis? And then, some of these patients have been told they have to drink lots of water. So, they're sitting there with liters, 2 liters, 3 liters they're consuming per day because they've been told drinking lots of water is good for the body. So it's important to just evaluate. And then others are just being fed on porridge and tea the whole day, a whole flask. So it's important to evaluate how much is the fluid intake, so that, reducing it also significantly helps to reduce the urinary symptoms. But quite a number of them tend to have an overactive bladder. So they're not, by the time they get to the urine, to the bathroom, they've already peed on themselves. So there are medications now that significantly help to reduce some of the symptoms. And they not only work for men, but they also work for women with big names, mirabegron and solifenacin. They do help to reduce, and tolterodine. They do help, oxybutynin. They do help to improve the quality of life. So that helps with urine. With stool, yes, it's true. Quite a number of patients also sometimes experience stool incontinence. I've seen that in patients who have also big prostates, so benign prostate hypertrophy, so that as they strain to pass urine, they also find that they've passed stool. And then again, others, because of the neurogenic effects on the GI, some patients actually are just having, persistent diarrhea, and using drugs like the ones that stop diarrhea may not necessarily be a safer option in the long term, but you may find that some of the medications that treat neuropathic pain, like pregabalin, gabapentin, also have a bit of effect in terms of reducing the diarrhea. And part of being elderly is use of diapers. So, adult diapers. And that's why I said it's important to get the family on board, because you may try all, medical therapies that are relatively safe. That, for example, if the patient already has peripheral neuropathy and you want to address that, you're using pregabalin for that, and at least it's helping you to reduce diarrhea. But you may find that, yes, use of diapers may just be part of life of this patient. And those are some of the things, unfortunately, that some of our patients are not willing to comply. They do not want the special care. And so I'm hoping that part of the participants, even as we age, we also agree to receive this special care from our loved ones. We will not be obstinate and be uncooperative.
So true. I think usually that is a difficult thing, but as age catches up, sometimes it's inevitable, and we just have to accept things as they are. I think just to add, as you were talking about the patients who take gallons and gallons of water, I think the other important thing to mention is patients who take sweetened dairy products as well as lots of milk. I think, especially in some cultural communities, those are considered quote unquote benign drinks, but they still do worsen your HbA1c control. And it's important for us to have that at the back of our minds. When we talk to patients, they tell us they are doing well and they're not taking any things that could be harmful. Perhaps you need to ask about sweetened dairy products, and you find that's where they're probably getting their extra sugars from.
In fact, now that you've mentioned the issue of milk, yes, quite a number of our adults, are lactose intolerant. So, as they're consuming lots of milk, expect that some of the GI effects they're going to have is the diarrhea. So looking into the diet sometimes significantly also helps to manage some of those GI symptoms.
Great. I think we have one of the attendees responding to our earlier question about metformin. The new study indicates that we can continue metformin in less than GFR of less than 30 mL per minute, and there's no risk of lactic acidosis as previously presumed.
Okay.
Maybe another question, set of questions was concerning diet. I saw someone asked, can we limit the diet to proteins, vegetables, and fruits only? I think
proteins, we give them proteins and vegetables and fruit only.
Yes, and sort of get rid of the carbohydrates.
Oh no, unfortunately that's not possible. So there was quite a lot, by the way, in terms of the nutritional and the dietary aspect. So apart from protein, calculations were something like 1 gram per kg per day. Even the calories, there were studies that were showing if they're taking less calories in a day, and you're talking about less than 25 kilocalories per kg per day, that is again associated, with worsening of the sarcopenia and the frailty. And then again, if they're overdoing it, they're doing, for example, more than 35 kilocalories per kg per day, then again, so it's something that, you cannot limit and put them, as I said, like the way we sometimes do when we're trying to on a very low carbohydrate or, carbohydrate diet. But again, a very high carbohydrate diet is also going to increase weight significantly, and you can see quite a number of them have physical inactivity. So there is a narrow range there where they can work with, but it's important that they work with a nutritionist. So in fact, I didn't include it in this presentation, but there is also a picture that depicts how the body mass and the skeletal mass significantly reduces with age. And there is a rapid decline somewhere between 60 and 70. And then, the decline starts from 40 to 50, slight decline, 60 to 70, it continues significantly, 70 to 80, up to, the point where even the height also reduces. So it's important to appreciate that the body composition and the physiology as we age is different from the time when we are growing, and take into consideration that even as we feed them.
Great, I think that's well answered. I think the other question that I have seen come up again is concerning supplements and whether they impact glucose control. And someone also asks, is there any consequence of combining DM drugs, e.g. glucophage and glifempa, with other nutritional supplements like calcium and magnesium?
Okay.
So the role of supplements.
Well, so these patients are also quite at risk of osteoporosis, osteopenia. So part of their treatment may be calcium, vitamin D, bisphosphonates. Remember, they're also at risk of fractures and falls. So that may not necessarily impart on their glycemic control. Yeah, I don't think that, but some of the supplements, I think, maybe are added on because, they are considered natural and they are supposed to be helping with metabolism and other kinds of, because of medications, because the perception out there is that they're sort of safer. There might not be a lot of evidence about those safer herbal supplements, but there are patients who will need the calcium, the vitamin D, because as I mentioned, the risk of osteoporosis, osteopenia, risk of falls, fractures is present, and they will need to have those on board.
Great. I think that's well answered. There's also one other question about when is best to do the blood sugar monitoring. I think you mentioned that in your presentation, but perhaps you can just recap. Someone asked, for a patient who does about 3 blood sugar tests a week, should they ideally do fasting or 2-hour postprandial, which is best? Patient already on insulin therapy.
I think it's important at least to have some fasting and some postprandial. So if you're doing a fasting, you can even have a 2-hour after lunch, and probably a 2-hour after dinner. But I even say that even as you do that, it's important that when the patient feels unwell, even if you have done your 3 readings for the week, you check. Because sometimes the fastings give you this impression that things are well. Then you check the 2-hour postprandials, and then the numbers look like things are not going as well as we thought.
Sure, agreed. I think You have to tailor it to your patient and make sure you adjust accordingly. Well, I see maybe we can take one last one that's still within the scope of today's discussion. So for a geriatric who is overweight, diabetic, hypertensive, and unable to walk and uses metformin and other supplements, is there any complication that might arise from the use of too much drugs, and are the organs at higher risk of failure or complications?
Okay, obesity. I know we may not have discussed obesity by itself here, but obesity does come with its own set of complications. This patient is at higher risk of osteoarthritis, heart failure, there's sleep disordered breathing, hypoventilation, diabetes, asthma. So there's all of that. So, and majority of them are likely also going to be on multiple medications because of the various comorbidities that they have. But again, even as we choose the medications, we said it's important to prioritize what are the symptoms the patient is having and how best can we address them. Most of our medications generally are not likely going to cause organ dysfunction if they're used well. The organ dysfunction that we tend to see, is because of uncontrolled, whether it's diabetes or hypertension. So we're not likely going to say the medication is the cause. And again, as we've said, organ dysfunction with age is likely going to happen. So that's another important consideration. So unfortunately, most people will tend to think that the organ dysfunction was because of the drugs and not necessarily because of the underlying comorbidities. Sorry.
Thank you, Doc. I think that's well answered, and we should be able to consider both the medication as well as the underlying comorbidity as causes of the complications.
Yeah.
I see we are quickly running out of time. Yes. I have tried to filter the questions that are really related to the topic of the day. And I think, as I mentioned earlier, for us, we are doing this as a two-part series. So this was part one, and we'll have a part two coming up.
Yeah.
And that will be March 11th.
Yeah.
That's 2 weeks from now. And I think part of some of the questions that came up will be answered within that discussion for the next presentation, where we'll be looking especially at the polypharmacy and complications. But I think I'd like to wrap it up there. And just to thank you all for actively participating and asking questions. And I believe we all have had our various take homes from this presentation. At least at bare minimum, we need to understand the complexities of managing elderly patients. And remember, it's a multidisciplinary approach. And remember to prioritize, discuss the priorities with your patient and encourage them to have social support and at least a young person who is coming to the clinics with them so that you're able to have better and comprehensive care for them.
Okay.
So before we wind it up, I think just on your slides, you can see how to join KDSG, which is Kenya Diabetes Study Group, and we have a conference coming up, and we hope you can spare time to join us for this educational activities. And once again, thank you for your time and do have a good evening.
Okay, good evening, everyone.